Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Nausheen Firozuddin, Assistant Professor and Consultant Histopathologist in Department of Pathology. Today, I'll be discussing with you in this presentation the intestinal malignancies. This is a fourth lecture on intestine. In this lecture, I'll discuss with you the main malignancies and the common areas of those malignancies. Especially, I will emphasize on large intestinal malignancies in this presentation. So the learning objectives of this presentation is that by the end of the session, you should be able to know about the introduction of intestinal malignancies, epidemiology, site, etiology or risk factors, pathogenesis, morphology, sign and symptoms, staging, prognosis, treatment, and little bit knowledge about the tumors of anal canal and appendix. Now, from the beginning, you know that the gastrointestinal tract comprising of esophagus, stomach, small intestine, large intestine, anal canal. So here I am only discussing with you the malignancies of large intestine. And we all know the large intestine is lined by a glandular epithelium. So the tumor of the large intestine is most commonly is the adenocarcinoma. Adenocarcinoma of the colon is the most common malignancy of GIT tract and it is the major cause of morbidity and mortality worldwide. However, the small intestine, which accounts for 75% of the overall length of the GI tract, is an uncommon site for benign and malignant tumors. So the most common sites for benign and malignant tumor is basically the large intestine. Among malignant small intestinal tumors, adenocarcinoma, well-differentiated neuroendocrine tumor, which is also known as carcinoid tumor, have roughly equal incidence followed by lymphomas and sarcomas. So by definition, intestinal malignancy is a malignant growth of tumor that begins from the inner wall of the colon or rectum and that can also involve the anal canal. So any malignant growth that begins from the inner wall which is basically the mucosa of the colon or rectum, it is called as intestinal malignancy or tumor. Regarding epidemiology, it is the second to third most common malignancy worldwide. Approximately more than 1.2 million new cases occurs per year. Most common gastrointestinal tumor in US, less common in Africa and Asia and parts of South America. More commonly occurs in men than women and it is the most common cause of cancer-related death among the non-smokers. Its peak age is 60 to 79 years. Less than 20% of the cases occurs before the age of 50 and it is rare before the age of 40, except in patients with predisposition syndrome, which I'll be discussing with you in my later slides. The intestinal malignancies, they arise anywhere in the colorectum, but the sigmoid colon and the rectum are the most common sites. Regarding the risk factors, older age, obesity, physical inactivity, alcohol consumption, inflammatory bowel disease such as ulcerative colitis and Crohn's, schistosomiasis, and family history of colorectal neoplasia are the main risk factors. We also include certain syndromes which are known as polyposis syndromes. For example, familial adenomatous polyposis, which is also called FAP, and variants are associated with adenomatous polyposis coli gene mutation. Then we have Lynch syndrome and variants which are associated with MLH1, MSH2, MSH6 and PMS2 gene mutation. Juvenile polyposis associated with SMAT4 and PTEN gene mutation. Porch-Jager syndrome associated with STK11 gene mutation. These are the symptoms are very important because if a person suffering from any one of this syndrome are more likely to have the sigmoid colon or rectum tumor. We also have certain other factors like dietary risk factors which increases the risk of developing carcinomas in the large intestine or small intestine. Those factors are low vegetable fibers, diet, high refined carbohydrates, increase beef consumption, decrease vitamins A, C and E. These low fiber prolongs transit time, especially the toxic oxidative byproducts are in larger contact with the colonic mucosa and they alters the bacterial flora of the large intestine. Then beef consumption enhances synthesis of bile acids by liver, which may convert it into the carcinogens by bile acids. Now discussing the pathogenesis, there is a combination of molecular events that lead to the colonic adenocarcinoma. These combination of events are of two types which follow basically two pathways. One is the APC beta-catenin pathway, which is activated in the classic adenoma carcinoma sequence, and the other is the microsatellite instability pathway, which is associated with defects in DNA mismatch repair and accumulation of mutation in microsatellite repeat regions of genome. So I'll be discussing one by one each with you in my later slides. So first of all, the first pathway. So the first pathway is the classic adenoma carcinoma sequence. It accounts for about 80% of sporadic colon tumors and typically includes mutation of adenomatous polyposis coli early in the neoplastic process. So APC is a gene which is present on chromosome number 5q. It is needed that the both copies of this APC gene becomes functionally inactive, either by the process by inheritance or by acquired means. So if this occurs, this is called first hit. Later on, when there is a methylation abnormalities and inactivation of the other normal gene, it is called second hit. This will cause the activation of beta-catenin. APC is basically interlinked with beta-catenin. So loss of adenomatous polyposis coli gene will activate the beta-catenin, which in turn causes the activation of transcription gene MYC and cyclin D1, which leads to hyperplasia or proliferation of the epithelial cells. Later on, this is followed by another gene which is called as KRAS. KRAS is a gene which is present on the 12p. It acts as a proto-oncogene which causes the activation of multiple another genes like SMAT2 and SMAT4, and it causes the inactivation of TP53 gene which is present on the chromosome number 17, which is the basically tumor suppressor gene. When this gene is inactivated, it causes the proliferation of the epithelial cells and result in a formation of adenomas. These adenomas also shows overexpression of the COX-2. This COX-2 causes the prostaglandin E2 production, which causes the epithelial proliferation. So KRAS promotes growth and prevent apoptosis, and if the adenoma is less than 1 centimeter, 10% are then subjected to carcinomas. But if the adenoma is more than 1 centimeter, then there is a 50% chances that this adenoma is going to be a carcinoma. So the additional mutation and gross chromosomal alteration in the adenoma will lead to carcinoma. So this is the basic first pathway in which the adenomatous polyposis coli is the main gene which either by first hit or second hit leads to the formation of a carcinoma. The second pathway is the mismatch repair pathway of colon carcinogenesis. In this, the DNA mismatch repair deficiency causes the mutation accumulate in the microsatellite repeats, a condition referred to as microsatellite instability. Microsatellite instability is caused by defective DNA mismatch repair. It is characterized by increase or decrease in nucleotide sequence, which causes the evasion of apoptosis, development of the malignant mutation, and tumorigenesis. So, in this, the germline mutation either by inheritance or somatic acquired mutation of mismatch repair genes occurs, which involves the multiple genes like MLH1, MSH2, MH6, PMSI1, and PMS2. They causes the alteration of second allele by LOH, mutation of or promoter methylation. They causes the formation of microsatellite instability, which result in a serrated sessile adenomas, and later on the accumulated mutation in genes that regulate growth, differentiation, and apoptosis. For example, TGF, BAX, BRAF. These are the genes which regulate the growth of the cells, differentiation of the cells, and apoptosis. But when these genes get mutated, this causes the development of carcinomas. Intestinal malignancies can occur in any site of the intestine, but the most common site regarding the intestinal tumor is the rectum. 60% of the tumors occurs in the rectum. Then 25% of the tumor involves the sigmoid colon and the descending colon. After that, the most common site is the cecum and the area of the ileocecal valve. Then the ascending colon and hepatic colon and the splenic flexure comprises the 5% of the tumors, and the transverse colon as the rare site for the development of the carcinomas. Now in this diagram, I'll be showing you the gross appearance of these intestinal malignancies. In the left side, or we can say on the right side of the colon, you can see this is a cecum. This is a cecum, this is a small intestine, this is the ileocecal junction, and this is an appendix. This is a part of the ascending colon. So at the junction of cecum and ascending colon, we have a tumor which is this like a fungating growth, and on gross morphology you can see there are polypoid overgrowths or fungating growths which is protruding into the lumen of the of the large intestine. These tumors, intestinal malignancies, either can occur in the form of a fungating polypoid growth, or in the left side on the left colon area you can see a picture of another type of the tumor, which is basically a napkin ring showing a napkin ring configuration. This tumor is not present in the lumen, not arising from the mucosa. This basically here you can see this shows a thickening in the wall. This is a mucosal surface of the large intestine, and you can see this is a narrowing of the lumen. The tumor is present within the wall, not in the lumen, not protruding out from the mucosa. It is causing the thickness of the wall, and this is another example which is called as napkin ring configuration. So the intestinal tumors can occur in any of the two forms. Either they can be fungating, they can be napkin ring like, they can be ulcerated, or they can be infiltrative, right? So the tumors grossly can occur in any one of these forms. Now on the gross, you can see that this is a large intestine, and here you can see the shiny mucosa of the large intestine. Here you can see a round fungating tumor which has an elevated margins and folded, and it shows a hyperemia. So this is one of the example of intestinal tumor which is a fungating morphology. Then here on the in another slide, you can easily appreciate that this is an uh, omental fat, and these white patches are basically the infiltrating tumor which cross the mucosa muscularis propria and infiltrating the subserosal fat. So the tumor can occur like this small foci of invasion within the wall extending up to the subserosal fat as well. Next, in the another slide, showing you the morphology which we see in the microscope. So the adenocarcinoma of the large intestine can occur in any of the following um, uh, type. They can be glandular morphology, they can be mucinous morphology. In glandular morphology, you can easily see that these are the glands which are closely packed. They don't have any gap in between. They are forming complex glandular architecture either in the form of cribiformation. They are irregularly enlarged. They are lined by the cells which are showing hyperchromasia and pleomorphism. Here in this side, the glands are enlarged. Some are small, some are markedly irregularly dilated. These glands have luminal mucinous pools, and you can easily see there are some isolated cells within the mucinous material. And the lining epithelium shows hyperchromasia, pleomorphism, and the features of malignancy. So the adenocarcinoma can occur in the form of a glandular morphology, in which we are graded them well differentiated, moderately differentiated, and poorly differentiated. They can be mucinous, they can be signet ring cell type, any of the morphology you can see in the adenocarcinoma. Now, how these malignancies appears? What are the signs and symptoms in the patient? Usually, these malignancies are subtle and non-specific, and they do not show any symptoms in the early stage. But when they show generalized symptoms. For example, the person may present with sudden change in bowel habits, like may have prolonged constipation or may have diarrhea. They bleed from rectum or they show blood in the stool. They will have vague cramping or abdominal pain or discomfort. The person may present with bloating, nausea, and vomiting. Later on may develop secondary obstructions which can lead to perforation or bleeding. In advanced stage, the patient presents weakness and tiredness. They will have iron deficiency anemia, unintentional weight loss, may show increased liver enzyme, especially the AST and ALT enzyme, which is the sign of liver metastasis. Then the patient may present with the hepatomegaly and jaundice in advanced disease. Prognosis. The prognostic factors includes the stage, the margins, the differentiation, tumor budding, perforation, lymphovascular perineural invasion. So if the tumor is high stage, for example, stage 1 if the tumor is involving the mucosa only, stage 2 if it is involving the muscularis propria, stage 4 is that when it is extending from the muscularis propria to the subserosal fat or the external attached organs. So the high stage will show the poor prognosis. If the excision is incomplete and the margins are positive, it is showing a poor prognostic factor. Then poorly differentiated tumors are worse tumors and they have a poor prognosis. And if the tumor has a morphology of single-ring cells, they are also poor prognostic. Then flat or ulcerative growth, tumor budding, the tumor which is showing perforation, free tumor cells in the peritoneal space, lymph lymphovascular invasion, perineural invasion, these are the poor prognostic factors. Then there is an immunohistochemical stains which is called as CDX2. If the lacking of CDX2 expression and reduced claudin expression, it shows a worse survival in stage 2 tumors. Treatment regarding modalities, we have first of all the resection with endoscopic follow-up. Then we can do local excision for early rectal carcinoma. We can do surgical excision of isolated distant metastasis, and after the histopathological diagnosis, the tumor is subjected to radiation therapy or chemotherapy. This is a picture which is present in your Robbins book, in which the American Joint Committee of Cancer TNM's classification of colorectal carcinoma is given. Here, if the tumor is in situ or dysplasia or intramucosal carcinoma, they are categorized as stage T1IS. If the tumor invades submucosa, it is staged as T1. If the tumor invades into the muscularis propria but not passing through the muscularis propria, it is stage 2. If it is passing through the muscularis propria, it is T3. And T4 when it penetrates visceral peritoneum or invades adjacent organ, it is T4. So in this way we classify the tumor on the basis of stage. So the high stage or T4 tumors are having worse prognosis. However, the in situ or intramucosal carcinomas having less worse prognosis. Tumors of the anal canal. Now comes to the tumor of the anal canal. Epithelial tumors of the anal canals are very uncommon. Benign tumors of the anal canals, including multiple warts, which are also called as condyloma acuminata, are the common tumors of the anal canal. In malignant tumors of the anal canals, it includes squamous cell carcinoma, basaloid carcinoma, mucoepidermoid carcinoma, adenocarcinoma, rectal of anal glands with anorectal fistula, undifferentiated carcinoma, and the malignant melanoma. So these tumors resemble in morphology with similar lesion elsewhere in the body. Now comes the tumors of appendix. Tumors of appendix are rare as compared to tumors of large intestine. And the most common tumor of the appendix is the carcinoid tumor. Other than this is the pseudomyxoma peritoni and adenocarcinoma. But the most common is the carcinoid tumor, and it has the similar morphology as we have the carcinoid tumor morphology on the other side. For example, in the stomach, in lung, in pancreas, the same morphology. In appendix, the tumor is the best site for the tumor is the tip of the appendix. They appears as a nodular lesion. Here it is yellowish in color. present on the tip of the appendix. On the H&E slide, they appear as a nest of the small cells. These cells show hypochromatic round nuclei with inconspicuous nuclei and scanty cytoplasm. The mitosis is minimum, and these nets, they show immunohistochemical stains, chromogranin positivity, synaptophysin positivity. Okay, so these are the tumors which are most commonly found in the appendix. Now the summary. So familial adenomatous polyposis and hereditary non-polyposis colorectal cancers are the most common forms of familial colon cancers. FAP is caused by APC mutation, that is the adenomatous polyposis coli mutations, and patients typically have more than 100 adenomas and develop colon cancer before the age of 30 years of age. So usually, as we discussed in our previous slides, that the intestinal malignancies occurs within the age of 60 to 80. But if the person is suffering from FAP syndrome and if they have more than 100 adenomas, they are likely to develop cancer before the age of 30 years. Then the hereditary non-polyposis colorectal carcinomas is caused by mutation in DNA mismatch repair enzymes. These patients have far fewer polyps and develop cancer at older age than FAP patients, but younger ages than those with the sporadic colon cancers. Okay, so FAP and HNPCC typify distinct pathways of neoplastic transformation and progression that also contribute to the majority of sporadic colon cancers. Nearly all colonic cancers are adenocarcinomas. The two most important prognostic factors are the depth of invasion and the presence or absence of lymph node metastasis. So if the depth of invasion is up to the serosa, it has a poor prognosis. And if there is a presence of lymph node metastasis, the tumor is more worse. Then we discussed the acute appendicitis is the most common in children and adolescents. It thought to be initiated by increased intraluminal pressure and compromised venous outflow. The most common tumor of the appendix is benign carcinoid, and the another tumor is the peritoneal dissemination of the mucinous tumors, which can cause pseudomyxoma peritonei. Thank you, and revise these topics by reading the Robbins book, and if you have any query, you can email.